Good morning, everyone. This is Carly Houchin at the Kansas Health Institute. We'll get started in just a few minutes here. Still see folks in the process of joining, but wanted to let you know you should be seeing the agenda for our meeting this morning on your screen now, and also wanted to give everyone a heads up that our live stream has started. But we'll get the meeting underway in just a few minutes. Good morning, everyone. This is Carly at the Kansas Health Institute. Seeing quite a few people getting on the line here, but just wanted to let you know that we'll get started in just a few minutes, right at 9. But you should be seeing now the agenda on my screen for our meeting today, and our live stream for the meeting is underway as well. But we'll get started in a few. Okay, good morning, everyone. This is Carly Houchin at the Kansas Health Institute. I show 9 o'clock, so I'm going to get us started here. Thank you for joining this subgroup meeting on telehealth. As a reminder, this group is working to make recommendations to the Special Committee on Mental Health Modernization and Reform that can be part of a 10-year strategic vision for modernizing the behavioral health system in our state. I'll overview the agenda and materials for our meeting today in just a moment. But first want to see if Eileen at the Revisor's Office is available to give us the statement on open meetings.
I am, Carly, thank you. This is Eileen Ma with the Office of Revisor of Statutes. And due to health and safety concerns, members of the public are not in attendance at this telehealth subgroup meeting of the Special Committee on Mental Health Modernization and Reform Working Group. But full access to this meeting is being conducted by medium of interactive communication, allowing members of the public without cost to listen on the internet and teleconference as available. The live stream of this and all other working group meetings of the special committee may be found on the Kansas Legislative YouTube channel. The agenda and all other documents for this meeting have been provided by the Kansas Health Institute, and a link to the documents may be found on the Kansas Health Institute website at https://www.khi.org/pages/capital M, capital H, capital M, capital R, dash, capital W, capital G. Additionally, a link to the documents has been provided in the description section of the live stream on the Legislative YouTube channel. Each member of the Telehealth Subgroup and staff will state their name and title each time that the individual begins speaking or voting, so that individuals can be readily identified by remote listeners. All participants are required to ensure that microphones, telephones, or other electronic devices are muted when the participants are not speaking, so that the ability of remote listeners or observers to hear the proceedings is not unnecessarily impeded. Public comment will not be allowed at this meeting. During this meeting, the committee will not recess to a closed or executive meeting pursuant to KSA 75-4319. Each motion, if any, will be clearly stated before the working group votes, and the chairperson will announce the results of the final vote. And that's it, Carly. Thank you.
Very good. So this is Carly Houchin again from the Kansas Health Institute. Thank you for that, Eileen. Okay, so as a reminder to the group, our primary goal of our meeting today is to check in on the recommendations that the group drafted at the meeting on Tuesday. You should have received a rough draft of that language with the meeting materials for today. And what we are trying to do in the next hour and a half is get to our list of high priority recommendations that we will put forward to the special committee. So the meeting materials you should have received for today, again, was that copy of the draft recommendation language. That will probably be a helpful document to have out in front of you over the course of our call this morning. I'll have a working doc version on the screen, but just for ease of reading, that might be a good document to have open in front of you. We'll do some introductions in just a moment, just so everyone knows who is on the line. And also with kind of our primary goal of the meeting in mind of trying to get to some of those highest priority recommendations, I will ask everyone as you introduce yourself to flag for us the one most important recommendation to you, at this point. So that'll just be to kind of give us a starting point on where we are in terms of getting to that those top 4 or 5 recommendations. So after those introductions, we are going to do a quick review of the language of the telehealth recommendations that had been drafted, just to see if there are corrections that the group has to offer on what was drafted based on the initial discussion. And then from there, we'll spend the bulk of our time prioritizing the telehealth recommendations to get to the top 4 or 5 recommendations similar to other topics, working group members. Then as time allows, we're going to review a quick vision statement that we have drafted based on comments made by this group on Tuesday. That will be just helpful framing language in the working group product, so that the special committee has a sense of where this group envisions the work needs to go in terms of getting to that modernized behavioral health system. Then from there, we'll have a few quick minutes for some administrative updates just to fill you in on next steps with this work, and we will adjourn by 10:30. So with that, let me start a new screen share to put that draft list of recommendations in front of you here. And again, you should have received this as materials for today's meeting as well. So if this is too small, I would encourage you to reference that as well. But want to run through introductions quickly here. So if you want to just briefly state your name and your organization so that everyone knows who's on the line, and then pick one of the draft recommendations, and feel free to just reference it by that bold handle at the start there. Pick one recommendation that is standing out to you at this point as your highest priority. And with that, the first person that I'm seeing on my list, if you're ready to go, would be Representative Ballard.
Okay. Yes, I'm Barbara Ballard. I represent State Representative 44th District, and I live in Lawrence. And my top priority right now would be the privacy to ensure the utilization of HIPAA compliant platforms and other technology for the delivery of telehealth.
Great, thank you, Representative. Next, I see Lisa.
Hi, Lisa Southern, Executive Director with Compass Behavioral Health. You're killing me with one choice, but I'll go with reimbursement codes.
Very good. Thank you, Lisa. Next, I see Andrea.
Sorry, Andrea Clark with the Behavioral Health Services Commission at KDADS. And if I would have to second the previous recommendation of the top priority would be reimbursement codes.
Very good. Next, do I see, is that Dawn? Dawn, are you able to unmute? Okay, we'll come back. Representative Bishop?
Representative Elizabeth Bishop. I represent District 88 in Southeast Wichita. And my choice would be supervision hours, simply because I have sort of concentrated some of my work on the recruitment, training, and retention of personnel. And I think that is related to that. Thank you.
Very good. And Dawn, it looks like you might be unmuted now.
David Jordan, and I would go to reimbursement codes as well.
Oh, apologies there, David. Dawn Jordan is on another working group, so I was thrown off by D Jordan there.
Not a problem.
Okay, next I see Fran.
Hi, Fran Seymour Hunter, substituting for Sarah Furtick today. I'm kind of like Lisa. There's a lot on here I would like, but I guess for my number one, it would be the guidelines and measures.
And Greg.
Yes, Greg Hinnon with 4 County Mental Health Center. I would say telephonic services. Even if broadband gets expanded, we have several in our frontier areas that are too poverty stricken to be able to subscribe to internet. So the telephone has been critical for our connection with them.
And Kyle.
Kyle Kessler with the Association of Community Mental Health Centers. And again, I've already heard 3 that I would be tied with the one that I'm going to mention, but virtual co-responder models. And that actually, in my mind, can be combined pretty easily with telehealth for crisis services. But in listening to law enforcement a lot recently, that seems to be something that would be a priority.
Great. And Rachel?
I think my priority would be, I can't see, it's the one related to foster children, and particularly related
Maintain
to
providers.
Yes, thank you. Maintain
You're
providers. My glasses weren't working with me this morning.
Well, I was choosing between those 2. That's why I knew where you were going.
Okay, thank you.
Great. Next, Sandra.
This is Sandra Berg with United Behavioral Health. Can you hear me?
Yes.
Okay. I would actually combine the guidelines and measures with the quality assurance, but between those 2, probably the guidelines and measures.
Very good. Dr. Warrens?
Yeah, Will Warrens, Sunflower Health Plan, Kids TLC, and the Guidance Center. And I think I love all these topics. I guess, the one that's sticking out to me is the 2 about sites, non-clinical sites and originating site.
Very good. Sunny?
Hi there. Thanks so much. I'm very focused on a lot of these too, but I'm leaning towards quality assurance, really with the emphasis on basic training to make sure that anyone who is working in the telebehavioral front understands, how to really examine when a patient is in need of more aggressive care, in-person care, things like that. Thank you.
Great. Dr. Nelson?
Good morning. I'm Evelyn Nelson. I'm a psychologist and professor at University of Kansas Medical Center. I'm really on the fence between the quality assurance and supervision hours. I think I'll lead with quality assurance, just the idea that we're delivering our strongest possible services over telehealth.
Very good. And Shane?
Yeah, I would focus on the services from non-clinical sites so that we can efficiently and effectively utilize our workforce that's out there across the state.
Very good. And Shauna?
Hi, I'm a psychologist and with KU Center for Telemedicine and representing the Rural and Frontier Subcommittee. And along the lines of reimbursement, I'm going to go with the sites, particularly I think the top priority for us is the originating site and the ability to reach consumers in their homes.
Very good. Thank you. Okay, any working group members or invited experts that I have missed in introductions here? Running through the list. Okay, I think we've heard from everyone then, so I will take us on to our next agenda item, which is a quick review of the recommendation language that we have drafted so far. So I heard a couple of comments in introductions there about places where the group might be interested to combine recommendations, so we can get to those in just a moment. I also, whenever I sent this out earlier in the week, I offered the opportunity to send any notes or edits in advance just so that we could have those ready to drop in. So I will flag for the group I believe the one comment that I got in advance was related to the guidelines and measures recommendation. And apologies if this is small on the screen here, but there was a suggested edit to this recommendation that we add the statement established guidelines for audio only telehealth visits as well. So that addition has been made to that recommendation. But I want to pause there to see if there's any discussion, concern, or other comments related to that proposed change.
And this is Will Warrens. I'm the one who proposed that change, but now that I'm looking, I mean, we do have our own category down there. I just wanted to make sure that telephonic services would be discussed, maybe separate from televideo services. I think we all agree that telephonic services, the main purpose for them is access. But if you have a situation in which you could do audio only or televideo, I think most people would say that we should all lean towards televideo. And so what does that mean for guidelines for audio only and everything once COVID is done? That was my only reason for the edit.
Sure. Any discussion or comments from the group on that? Okay, not hearing any. Want to then let me first open the question up broadly, and then I flagged a few places where there's suggestions to combine recommendations during introductions. As you took a look at these recommendations ahead of our meeting this morning, were there any edits or suggested changes to these recommendations before we get too deep into the conversation of prioritizing here? So I'll take comments anywhere.
Carly, this is Sandra Berg with United. And on the state line issue, I think I sent you a note about making sure that we clarify where the therapist is located or the service provider is located and where the client receiving the services is located. We ran into an issue earlier this year with a restriction from the BSRB stating that both had to be in the state of Kansas. So if a person traveled outside of the state of Kansas, they weren't supposed to be receiving televideo, telehealth services outside of the state from an in-state person.
Carly, this is Barbara Ballard, representative. Clarification on that. What if the person lives here, but they happen to be there on a job or an emergency and everything else, but yet they want to continue their services. They're still a resident. Does that still say they have to be in the state if it originated from the state?
Representative Ballard, I think that was our understanding from what we got back from the BSRB, is that the person had to be located in the state when they got their service. We brought it up because we have foster care children. We have people that travel outside of the state for lengths of time and needed to have services rendered. But the answer we got back was no. So I think that needs to be clarified. We need to go back to the BSRB to make sure that that is the understanding.
This is Fran Seymour Hunter. I had the same question come to me in the Medicaid agency, and I actually have it in writing from the BSRB, and I'll just read what it says, and I can route this later on. As far as our statutes and regulations are concerned, the physical location of the individual receiving services determines the criteria for licensure. In other words, if the person receiving services is located in the state of Oklahoma at the time the services are provided, a Kansas licensee cannot use their Kansas license to provide services. The Kansas licensee must contact the licensing officials in the state of Oklahoma to determine licensing requirements. The COVID-19 pandemic does not change the Kansas requirements, and I will get that sent on so that it can be forwarded to everyone.
And this is Shauna Wright from the KU Center for Telemedicine. And really what we're looking at there is not just what Kansas says, but what other states say and what their regulations are. So Oklahoma is not going to invite a televideo or telehealth provider into their state, even if it's a resident of Kansas, because should there be an emergency or crisis, that person needs local and immediate care. And so we have to have agreements with the states. So even if Kansas said, you know, we're okay with that, states around us may not be. And so they have it in their regulations. So as an example, I had a patient that I was treating in Kansas who lost his job and went to live with his parents in Missouri for a short period of time during COVID. So my reaction, I'm not licensed in Missouri, I'm licensed here in Kansas, and I'm licensed in Nebraska. So I contacted the Missouri Licensing Board. I told them what was going on, and they told me their procedure for providing treatment in their state. There are protocols for that, even for traveling families and traveling workers, but it's on the shoulders of the licensed provider to contact that state, let them know they're doing practice in that state. Many states have temporary waivers. Some of them say no, absolutely not, but most of them will grant anywhere between 8 and 10 sessions. They just want to know that you're providing treatment to someone in their state, whether it's a resident or not, and that you've thought through emergency and crisis procedures and you're aware of what's available locally to that patient. So there is a structure and a framework. And I think that in a lot of ways, the BSRB's hands are tied with that they have to protect citizens and visitors in the state of Kansas when they're treated here, and every other state does that as well. However, we do know from, and so I wanted to go back to what Sandra said, I'm a licensed Kansas provider. If I were to go and have to relocate to take care of my mother in Texas, I'm still allowed, the BSRB would still allow me to come back in and through telehealth treat my Kansas patients because I'm licensed in this state. So I have to be licensed where I'm treating patients. I don't necessarily have to be physically located there. But we run into a lot of issues if we cross state lines. It violates our license because we're practicing without a license if we reach into another state.
Well, this is Representative Ballard. I'm going to thank you for that explanation because that just saved me 2 questions because you clarified all of that in the process. But I would like to just toss out something that I hear from that. Is this also, could it not be a financial issue as well? Because if you are putting somewhat of restrictions on it, even though you will allow, certain things, it also says that they want to make sure that you are not taking Oklahoma or whoever's patients that Kansas is actually being reimbursed for. That just sounds a little iffy to me.
There could be that financial driver. I don't think there's just one piece of the pie that answers the question. But in my conversation with regulatory boards, often they don't. Regulatory boards don't operate at a profit. They are usually pretty thin in their budget lines, and they are charged to protect the citizens of their state. And so the only way that they can do that is being fairly strict in what they expect and identifying any provider that is providing treatment. So for instance, I was worried I wouldn't have, when I started my independent practice, I was worried I wouldn't have enough patients in Kansas. So I went and got licensed in Nebraska. I've never used my Nebraska license. I've had enough work to do here in the state of Kansas. And so there's very likely a financial issue there. And some Medicaid boards won't impanel you if you're not physically located in the state where you're treating patients. So there's definitely that. But I think when we look at the regulatory procedure and the oversight, it's really hard to oversee the safety of your citizens if random people are coming in and they haven't identified themselves to you.
Thank you so much.
So this is Carly Houchin with KHI. I'm going to jump in there to attempt to clarify some of the language change that I heard in that helpful discussion there. So the addition that we've made to the drafted recommendation was adding the sentence that we need to clarify where therapists and individual receiving care may be located. Recognizing that we heard some of that clarifying information there, I've still added that tag with the thought that that information should inform kind of what options are explored to allow for services to follow Kansas residents as they go off to college or something like that.
And this is Shauna Wright again. The other thing I would add to that is, as telehealth is growing, we are seeing different professional boards and licensure regulatory agencies sign on to interstate compacts. So there is the SIPAC, where Kansas is not a part of that, and it's specific to psychology, not all professions. We see the nursing compact, where nurses can cross state lines with telehealth. So under the umbrella of modernization, we may want to be looking at what ways can we help our providers cross state lines when needed, and explore these compacts and make sure they're a good fit for Kansas.
So this is Carly at KHI. Working group members would be interested to hear how is this language sitting at this point? Are there additions or corrections that you would like to see to the language on the screen in row 103?
This is Sandra with United. And given what Shauna just said, do we need to change it to explore options for the, what did you call it, Shauna, interstate compact?
Yeah, interstate licensing compacts across profession.
Yeah. Rather than to allow for service provision, I think that probably is a key starting point to move us forward.
And this is Fran again. I do happen to be a nurse, and even with the interstate compact, they're very clear about the fact that where the patient is located determines the ability of your licensure that you need to, if you are actually doing practice in that state, you have to move forward in terms of checking with that state. And in most cases, you would have to get specific licensure within that state underneath the compact agreement.
Great, thank you. Okay, I've made some of those edits on the screen here. I'll make a last call for comments on that language. Okay.
This is Representative Elizabeth Bishop, and my only comment is that this arouses some curiosity relative to what statutes have to be addressed if they do. It sounds to me from the quote from the BSRB that there is something in statute that we might want to massage.
Mm-hmm. Great. So this is Carly at KHI then. In the interest of time, then I'll move us on. I'll go back to kind of the highest level question. Are there other recommendations that we know we need some language changes to make them as up to date or as precise as possible? So any other kind of high level comments on any of the recommendations you reviewed or language changes that we need?
Carly, Representative Ballard, I'll just toss this out. I don't know if we need it, but one of the reasons why I settle on privacy is that I have emails from my constituents, and often they'll tell me they would use telemedicine, but they want to make sure that privacy is being observed, and that they hesitate to do that because they're not sure. So in a way, that seems to me, unless we can make sure they understand it, it's a barrier. You know, it would be available to them, but they're not going to use it because they don't feel that it may be really confidential, and yet they know that might be the only thing they have available to them. So I don't know if there's any way we can add something to it in terms of you can't ensure confidentiality, but that we are aware that these might be issues, and we wouldn't want this to be a deterrent, you know, or yeah, do you understand what I'm saying? Let me give this to the experts on that, because that's what their issue is.
Can I make a comment? This is Shauna Wright from the Center for Telemedicine. Absolutely, that makes sense. And we know that in the Kansas Telemedicine Act, it speaks specifically to HIPAA. So our providers across the board know that we have to use HIPAA compliant. So legally, that foundation is there. But I think what you're speaking to is that piece of informed consent and education that we really require our providers to provide the telehealth education and the informed consent, so that we're reassuring them that we're connecting with them through HIPAA compliant and private means. So the piece that really needs to be filled is the educational piece and the patient engagement to underscore that.
Well, Shauna, this is Representative Ballard. That's addressing what I think their issue really is. And actually, it's my issue. I don't have to use telemedicine, but what if I did? You know.
This is Evelyn Nelson from KU Medical Center. I think hand in hand, making sure we're following overall best privacy, not just with the technology itself, but it's on the provider's shoulders to also make sure, you know, we're following all electronic health records components with privacy, and just setting up the room itself and the education to the patient about how to set up their setting, you know, where no one's listening at the door, those kinds of things. So I would just say it's beyond the just the technology privacy.
Thank you.
So it could go on to say that agency policies and procedures address confidential, secure, safe spaces for telehealth to be delivered.
This is Carly at KHI. Hopefully got something to the effect there, but we can tidy that up in a bit, perhaps.
This is Representative Ballard. This, when I read it now, it does address what I think are some of the concerns. So I thank you all for contributing to that.
Great. So this is Carly at KHI. I want to go back to a couple of things that I think I heard in introductions, and I'm going to try and move us through these pretty quickly here so that we can get to some prioritization work as well here in just a few minutes. So I heard a potential interest during introductions that there might be an opportunity to combine the recommendation on virtual co-responders with, so that's in row 105 on the screen, with the recommendation for utilizing telehealth for crisis services. Want to open that issue up for discussion in the group. So attempting to highlight both of those in yellow on the screen. Any interest from the group in combining those recommendations, or does the group prefer that they remain to stand alone?
This is Gary from KDADS. I think it's okay to combine the two. I think they're pretty hand in hand myself.
This is Greg Hennon with 4 County Mental Health Center. I would agree. I think it's a good idea.
Yeah, this is Will Warrens. I think it's a good idea, and I like what you're already doing, which maybe maybe the crisis services bullet point can be the parent, and the co-responder can kind of go into that as an element of the crisis services.
It's Representative Ballard. I'll agree with that, but because I wasn't here when these were proposed and I wasn't on the call, I didn't want to step on somebody's toes knowing why you put them there. But since you've all verified it, I think it really is a good idea.
This is Brenda Landwehr, and I would agree with Will's assessment of the crisis and the responders below that.
Very good. So I think I heard consensus there. The next issue that I think I heard while we were running through some introductions was a potential interest in, and let me turn off highlighting there, in combining the recommendation on guidelines and measures with the recommendation related to quality assurance. So those two are highlighted on your screen now. That's row 111 and 116. What's the interest of the group there? Do we want these as two standalone recommendations, or is there interest to combine?
Carly, this is Sandra with United, and my thought around combining those is once you have your guidelines and measures, you still need the quality assurance to make sure that those are being followed. So that's why I thought combining them into one made sense to me.
This is Kyle Kessler, and I would agree with that.
Gary Hinault, KDADS, I'm in agreement.
Okay. I am going to take that as a decision then. I'm not going to try and do that language on the spot since they're pretty lengthy there. I'll make that note for us so we can have that change. And then I'm just going to drop these numbers, combine these numbers, and turn off our highlighting. Any other maybe last call here for initial language changes to these recommendations?
Carly, this is Representative Elizabeth Bishop, and I want to kind of revisit the last discussion about virtual co-responders, et cetera, and make sure that it includes the ability for coverage for telehealth for individuals who are in a jail. I don't know if that relates to that or if that issue would be covered somewhere else, but I note that it the 105 refers to mental health crisis in rural communities, and I know that telehealth in the jail is something that I believe is being utilized now. I'm not exactly sure how it's covered.
Representative Bishop, I think on that one there is, I think that it's a different issue. To me, I look at the needs in our jails or our prisons, et cetera, being separate. I think that's different than the crisis and the responders. I understand where you're going, but I'm not sure that they belong in that combination.
This is Shane Hudson. I would just mention that we have some individuals signing in from jails currently for our substance use disorder treatment group since COVID has begun and restrictions have been lifted or lessened. One of the barriers I see is funding streams. How can I scale that to more patients in more jails if I can't get paid by that patient's insurance, or if they don't have insurance, maybe I'll tap into block grant. But for me, it's more of what insurance might exist outside of the jail versus when they enter the jail, and then what kind of funding gets pulled over to us and how will that work for reimbursement. So that's my bigger question there. Of course, telehealth delivery to jails helps us reach people who aren't getting services otherwise. So that's a good thing, but there's some other barriers layered in there.
And this is Shauna from the Telemed Center. Shane, can I ask your experience on that funding source, just a clarifying question? If we have an adult who is a Medicaid consumer and they are placed in jail, do they lose their Medicaid coverage, and does that put the burden on the jail to pay for the services?
Yes, and there's something called, I can't think of it right now. One of my staff told me the funding stream that kicks in, which we have not been billing, and I don't really understand it all that well yet. But yes, the Medicaid funding doesn't, the stream of that insurance doesn't happen while the person's in jail. I know there's been a lot of talk about it kicking in faster once they're released, but during their time in jail, we're not able to bill that.
Yeah, this is Andy Brown with KDADS, and block grant is a viable source for billing for mental health and SED services in jails. The key point is it's jails. But we can talk more about that offline, Shane, if you want. This is Gary from KDADS. I think going to the original question, I think the bullet we have under services in non-clinical sites certainly is one that might be part of that answer for jails. That we're looking at the ability for the client and patient privacy
That makes sense.
standards to be met.
This is Andrea Clark with KDADS, and a second place to plug. I'm not sure exactly where this would fit in or concern along with services in jails is you often have a second layer of technological barriers because of security systems, walls, your regular internet service or telephone services that would be available for telehealth on the outside often aren't sufficient to overcome the walls, literally, on the inside in a jail. So
you bring up a good point on this. This is representing Landwehr, is that perhaps that's where we need to reach out to, because I think we've got 2 or 3 sheriff officers that are on our modernization team. We have both rural and urban.
Yeah, I can make that note in the rationale over here that more information on precisely what supports to providing services in the jail setting might be.
Yeah, what those, you got to look, I think her point being is what are the barriers?
this is Andrea with KDADS. And yeah, I thank you. There are barriers to telehealth services within jails that aren't necessary barriers on the outside, including privacy. Often you don't have the ability for a patient to be in a separate secure area to be able to conduct a visit without being around other staff or inmates that would be that would violate that privacy for them. So there's significant enough barriers and differences, I think, on telehealth in jails, whether it's funding stream or technology, that, you know, I think as a recommendation, jail telehealth services might warrant its own line, frankly.
This is Representative Elizabeth Bishop again. And there was an audit done of jails. I think the date was 2018. And telehealth is one of the issues that was mentioned as a possibility for assisting, especially in rural areas where the jail staff is small, in assisting with their providing appropriate services for jail inmates that need mental health counseling, mental health service.
So I heard, this is Carly at KHI. I heard interest in there to pull out these issues related to jails as a standalone recommendation. So I'm trying to type as I listen here, and I think I heard something about exploring challenges to address related to provision of services in, well, I guess, telehealth provision of services in the jail setting, such as privacy, technology, and funding. Andrea, I'll check in with you there. Does that get to the issue you were raising, or what changes would you make?
This is Andrea, and that covers it. My only point was just that, you know, jail technology issues are different than telehealth technology issues outside of jails. Privacy, it's the jail privacy issues are a little different than outside telehealth privacy issues. So just, yeah, you captured my thoughts. Thanks.
Well, let me ask this is Representative Lamwer. Let me ask Representative Bishop a question. Is, I thought the idea of putting it under the non-clinical services would keep a focus on that, versus if we put it out there with its own line item, then we work with it in conjunction with other non-traditional sites. Would that be all right, Elizabeth?
Might be muted there, Representative Bishop.
Sorry about that. I would just like to see it addressed. If it's a subset within another area, that's fine. I realize that's one that we need to do some checking with the professionals dealing with this on a regular basis to see exactly what they would like, thinking of the future, which is what we're trying to do.
Right, and this is Representative Lamwer, and I just, my impression is as we've gone on these work groups and operating off of this type of sheet, it seems better for us, or it, in the long run, I think it's better the less boxes that we have, the less lines that we can make. Now, that's not always doable, and I understand that, but that's kind of what I was looking at. And then I think it would keep the focus so that it doesn't get lost somewhere else, because it's a good point.
Okay, this is Carly. Go ahead, Andrea.
Andrea Clark with KDADS. My interpretation of the line services from non-clinical sites is that the focus is on where the staff is located, providing those services, i.e. services from home or other sites, as opposed to where the patient and client is located. And I definitely agree with less bullet lines, the better. That would only be my concern. I don't know that jail telehealth services, you'd still have your staff or professional from their licensed clinical site. It's just that they're going into the jail through telehealth, as opposed to the staff being able to provide services from their home or somewhere else. That was really the focus of that bullet.
This is Shauna from the Center for Telemedicine. I agree with your interpretation, Andrea, but under the umbrella of reducing our boxes, traditionally that area, the services from non-clinical sites and even originating sites often fall under the umbrella of reimbursement. And I wonder if we could categorize it with reimbursement. So we have the idea of reimbursement codes, and then who qualifies for reimbursement, like where are they located? And who qualifies to receive services, where are they located? Those can traditionally be thought of as reimbursement issues. We're just saying that, we've looked at them differently in the past, and this is how we want to look at them now, but both of those reinform whether we receive reimbursement. So there could be a way to collapse all three of those into a reimbursement issue and talk specifically about codes, services from non-clinical sites, and then the originating site as well.
Representative Ballard, I will address the part on jails, because I have heard our sheriff and the deputy sheriff refer to a lot of the services. Now, maybe years from now, it may be a little bit better, but right now, a lot of times the jails are actually the people that are really incarcerating, but they also are expected to be helping, but they don't have people that are qualified in order to do the mental health. So then it becomes a financial matter, because then they'll have to bring in an outside person. And sometimes that may be too late because they needed that evening or whatever. So whatever we do, I don't think we should incorporate it so deep in there that we're not really saying that jails are not delivering those services, because they're trying to. And in some cases, there's no other place in the community to do it but the jail. So I just think we have to make sure we incorporate it so that we know that jails, if they have to deliver those services because they're not elsewhere, need to make sure that they are in line to get the funding or get the training, whichever.
And let me jump in there quickly. Dr. Nelson, your hand was raised. Do you have a comment?
Yeah, I really appreciate this discussion. I do think one thing that comes up with jails is both on-demand and scheduled type appointments. So some of the crisis assessment and some of those things, perhaps that's too far in the weeds for this discussion, but I think about the planning for both of those types of services And then as someone from the pediatrics world, just thinking through also the needs of youth in jail. We have used telehealth in the past with our psychiatrists assessing youth in detention centers. So I just think keeping the youth in mind and particular concerns might be something that needs to be addressed.
Great, thank you. I'll make that note over here. Okay, at this point, so this is Carly at KHI. Now, just in the interest of time, as I think we're starting to navigate, trying to figure out how to combine issues to get to kind of the priorities that sit right, I'm gonna go ahead and move us into the conversation on prioritization. So I'm gonna start by offering some framing that will be similar to some other topics and it might sound familiar to working group members. So I think we heard pretty clearly from the special committee that if everything's a priority, nothing's a priority. So with that in mind, our goal is to get to 4 or 5 highest priority recommendations on this topic. That being said, all of this work will be preserved and that will be included in the working group product and the report in our appendix related to this topic so that it can be taken up by additional groups and kind of further conversation and further work can be done when the timing becomes appropriate for that. So our goal is to get to 4 or 5 highest priority recommendations. To start us off in that conversation, I'll go ahead and just do a quick filter there. So what you're looking at on the screen, I just rearranged the order of the exact same recommendations we were just looking at by count of kind of who flagged their highest priorities there, just so we can see where that leads us in terms of the things people initially thought were most important. And bear with me here, I'm gonna squeegee some lines back so that we can see as many things at one time as possible. So we are trying to get to our top 4 or 5 recommendations. Right now they are sorted by the things at the top of the list are the things that more people at the start of this said were the highest priorities. I'll go ahead and maybe hide some of the rows that got combined into other things just so we can try and see our work all together here. So let me first pose the question. The recommendations highlighted in yellow are all of those that received multiple people on this call at the beginning said that, you know, their first thought was this was the most important issue. So the 3 things highlighted in yellow, want to ask if anyone on the phone has a concern with these things kind of being considered in that highest priority group. Any initial concern with these 3 items here highlighted in yellow being considered highest priority?
This is Will Warren. This isn't really a concern. I know that Dr. Wright had said the possibility of combining sites with reimbursement, and I don't know, maybe I blanked on it, but I don't really know where we landed on that, whether that was considered a viable option or not.
Sure, this is Carly at KHI. I'll open that discussion up to the group. I don't think we landed on a clear decision. It seemed like we were in that discussion trying to get into a place where we were prioritizing. So thought we should just transition to talking about prioritizing. And if it makes sense to combine reimbursement codes with others, feel free to toss those out again here and we can try and get to a final decision.
This is Shane Hudson. Another thing to mention in that conversation is originating site and distant site are discussed, of course, in reimbursement, and distant site would be, as we discussed, services from non-clinical sites. So I'm curious about making a line that says originating in distant site and then considering if that is a combination with reimbursement.
So I'm hearing interest from the group in combining rows 104 and 105. Any concern from the group with doing that?
Carla, this is Brenda Landwehr, and I think that the concern's going to come in the legislative realm of funding, because there's always a lot of caution used and a lot of discussion around opening up any reimbursement codes no matter what area of Medicaid that is in. If you combine that, I think with anything else, I understand the intent for combining them. I think you will dilute that discussion of the reimbursement codes, and it will be easy to set it aside. Should the discussion occur, I would agree that it does need to occur. What the decision comes out of that, I can't project.
This is Shauna Wright. I'd like to maybe have an exchange on that and understand your perspective a little bit more, because right now I think, and I don't want to speak for the mental health centers or for those that are providing services, but Medicaid does currently, even prior to COVID, they did cover reimbursement for most of our telebehavioral health services. What limited where those were dispersed were the sites. So for instance, if we had a work member who was injured but still wanted to work from home, they couldn't do that. Or if we wanted to reach into the home, that we couldn't do that. The biggest changes I think that we're looking at in terms of reimbursement aren't necessarily the codes, but the location of the provider and the location of the consumer. And I'm not sure, I'd like to hear from the mental health centers and from Shane, but previously we've had reimbursement codes. The restriction has been where the provider is and that the consumer report to a supervised setting rather than connect from the home. So I see those as the most pressing reimbursement issues, is broadening that availability, not necessarily opening more codes. But I'd like to hear from others if they're seeing that differently.
Yeah, Shauna, this is Shane with CKF Addiction Treatment. So one of the large barriers to really delivering telehealth, as telehealth should be delivered and received, is patients getting the service from their home, and having the flexibility for staff to deliver the service from a non-clinical site would be helpful for that delivery and receipt of services and a functional piece. As far as reimbursement codes, we had certain codes we could bill via telehealth in the past. Those are maybe the lesser intense services such as assessment, admission, level 1 individuals. Groups, I don't know that we'd quite gotten into that before COVID. Now with COVID coming in, our level 1 groups, our level 2 groups, as we're seeing get delivered and attended quite well and people giving positive feedback, that's been something that hadn't really been dug into in quite the same way we have. I can't really say that we've ever had a patient sign in for a group service from somewhere else versus being in person for the group service, but maybe if we really need to get them seen, we might not have gotten paid. So I think there is a code thing sitting out there as far as the extent of the codes we can use now versus what we were using before. And then there's the originating distance side as far as I've seen it.
So this is Carly at KHI. I am hearing several things there. Let me check in on them. First, I heard from Representative Landwehr interest to maintain these two recommendations distinct from one another. And then separately, just before that, I think I heard from maybe Shane that to this originating to the recommendation in row 105, we might combine that with the recommendation in row 111 about services from non-clinical sites. So I think what I heard is that we would keep the reimbursement code as a distinct recommendation, and we would combine the recommendations in row 105 and 111 to have a combined recommendation about originating and distant sites. And I would pull up the language from row 111. Concern or discussion from the group on that, or did you hear it differently?
Early, this is Sandra with United, and I wonder if the concern, and Representative Landwehr can correct me, is around the wording of expanded reimbursement codes, because when I read that, I do hear additional funding needed, but I don't think that was the intent of the recommendation. And I know it's related to how we expanded codes during COVID, but it's not really clear if you're just reading it out of context.
Yeah, this is around with KDADS, and I would suggest that maybe we add the language so that it says maintain public health emergency expanded reimbursement codes.
Well, then you raise, this is Representative Landwehr, so then you raise the question, and I can't tell you the answer off the top of my head. I bet you guys can at KDADS, is how many of this expansion currently was done through executive order versus House Bill 2016?
Most of the expansion was done through policy procedure.
Okay. And I think that's one of the things that as legislators, we will want to have that discussion, not saying that it was wrong, but so that we have a good handle on what it is that we have done so that we know what we need to do going forward. Does that clarify where I'm coming from?
Yes.
Okay.
Okay. So at this point, we have, I'm going to say it sounds like 3 high priority buckets filled in. As a reminder, our goal is 4 or 5.
Hey, Carly, this is Gary from KDADS. And I'm sorry I wasn't here at the very first few minutes, I think, when this voting was done, but I certainly would have voted for the telehealth and crisis services. I think that is certainly one that needs to be in our recommendations. The effect of that that we've seen in other states is huge, and the overall numbers of people helped through that kind of services is pretty large.
Okay, discussion from the group. I've gone ahead and highlighted that recommendation in yellow, indicating that it might be a strong candidate for high priority. Discussion from the group on that.
You mean on Representative Ballard? Do you mean on adding that?
Yeah, I'm considering that one of the highest priority.
I don't have any concern with that, but I do have a question. I see where privacy has been totally eliminated from the group. Did you intend to do that? Because I don't see privacy anywhere. And when I look at that, I still
It appears to be 108 just hid the title for the HIPAA or privacy line.
Okay,
should be right here. Sorry about that.
I didn't see that anywhere, and I figure if we cannot assure people of that, then we're not going to have them really going there or trying to get those helps. I don't know if we need to combine that with something else, but that is really a big issue for me. And I think because just my background and having counsel and everything else, that becomes the #1 issue if you want people to receive services and feel comfortable doing it. So, but I didn't see it.
Okay,
so this is Carly at KHI. I think I'm hearing interest there that be considered in the highest priority group. So now we have 5 that we've highlighted all the way yellow. I want to, so open to discussion on telehealth for crisis service. We've just added that to the yellow category, and we've just added the privacy recommendation to the highest priority category. Want to open discussion related to those 2 items specifically. Any concern from working group members about having those in this highest priority category?
Carly, this is Brenda Landwehr, and I definitely agree with the telehealth for crisis services and as well as the privacy issue. But I'm wondering if the privacy issue cannot be perhaps tied to the originating and distance site so that it's addressed in everything that we do on telehealth, because it has to be. There's not an option.
Yeah, this is Will Warrens. I agree with what Representative Landwehr was just saying. One other spin on it I have is that, perhaps, there was some talk about guidelines, and I think that's maybe migrated off of here. But if we're talking about guidelines, guidelines for privacy, guidelines for verbal consent might be ways of combining as well.
This is Shauna from the Center for Telemedicine. I see that as well. Wherever we put it, I think it's important, but I think we included the guidelines and measures under quality assurance. And I see that privacy issue fitting in with guidelines and measures and quality assurance. And, that we put the bold on it, that this is a priority within this priority. But I think that those all fit together, but particularly under the guidelines and measures.
So this is Carly at KHI. Representative Ballard, I want to pose the question directly to you. Then are you comfortable with the privacy recommendation being folded into the high priority recommendation on quality assurance, where we've also already included the expectation that guidelines be established?
Yes, I am. I wasn't sure where it went, but that's why I said we could combine with something, because quality assurance makes more sense to me, especially when we added all of the other components to it besides just that. So I am comfortable. I didn't see it and I thought, oh, whoa, that's not gonna work. Okay.
Yeah, thank you for catching that. Okay, so I'm gonna turn this one off from highlight. That creates one space in the highest priority category. Since we've done some combining there. So want to pose the question to the group. Is there another recommendation that's a strong candidate to be in that highest priority category?
This is Andy from KDADS.
Go ahead.
Oh, thank you. And I would suggest that we take a hard look at state lines on number 113. We're already seeing increased applications for licenses from virtual only providers from outside the state. And so I think this is something that if we're going to have legislative guidance on, it would be good to have that sooner rather than later.
Okay,
Andy, you just raised a very scary point. And I'm thinking, I'm sorry, this is Representative Landwehr. You know, I understand it when they're butted up against our borders. But just to have a telehealth service come in from out of the state to provide that, then that defeats our purpose of still saying that in-person needs to occur at some point in time.
Correct.
Don't give us scary things, Andy.
Oh, Representative Landwehr, you know you used to scary things.
Yeah,
This is Shane. This is Shane Hudson. Is the concern that a lot of providers outside of Kansas who aren't maybe as familiar with Kansas as Kansas providers or what have you are providing the bulk of, majority of, or get to that point where they're providing a lot of telehealth services, or that having more providers signing in from out of state would increase people's reliance on telehealth over in person? I was just curious.
I guess, and I'm not the professional here at the table with this. It's not in my real life world out here, is looking at it from just the work that I've done over the years, that in talking to professionals, that there still are points and times that that personal contact really is needed. We know that that's an issue, especially with some of our younger people, because there's a lot of body language and different nuances that a counselor will catch that they may or may not do on telehealth.
So then what we're saying here, for people to recognize when a person needs an in-person service, those out-of-state providers would not maybe follow that same guideline or get them connected to in-person services. Would that be the core concern?
Well, they could connect them to a person, but unless I'm mistaken, it's pretty important if an individual can continue with the same counselor, psychiatrist, etc., that they started with, whenever that's possible, because of the relationships and the trust that's built between those two individuals. That's my concern.
I agree. I guess I'm just not quite seeing the strong tie there between the out-of-state providers and continuing relationship and rapport and, you know, engaging with the therapist you've been working with.
Well, it doesn't mean that we can't do this, but I think it's definitely a discussion on its own, because we do know that we have a shortage in this area. But I think the first question comes about is, does telehealth help us address our immediate need on the shortages that we have to rely on the out of state? You know, I don't know. I think it's definitely a discussion that we need to have.
Yeah, this is
we
what
don't quite know where the shortage lies if we truly engage all of the providers that could be in the workforce. So that's something we don't quite know the answer to yet.
I would agree.
Yeah, this is Will Warrens. I think, you know, I think that what we're saying is the subject is important. You know, what the actual statement would be, you know, I'm not hearing that the statement is, well, let's accept all people from all different states and this, that, and the other. I think we're saying that the subject of state lines is something that's just going to be a very important one to discuss and figure out our stance, you know, in the next 10 years as we go forward with telehealth.
Okay, Representative Landwehr here, and Will, you said it the way I meant it. Thank you.
And this is Carly at KHI. I want to jump in. I think someone on the phone line, which I think could have been Sunny, was maybe wanting to weigh in there.
Hi, Carly. Yes, this is Sunny Mickle from Blue Cross and Blue Shield of Kansas. I wanted to support what Representative Landwehr was speaking about here. We find quite often that there is a challenge when you have out-of-state providers, even when they have a Kansas license. We hear from primary care providers every day that they are looking for that care coordination opportunity. And it happens much more when the provider is obviously located in Kansas. And at least if the provider, the behavioral provider in this case, has a Kansas license, they can be tied to a higher standard and understanding of what is expected to work with patients in our state.
Great. Thank you for those comments. Okay. So this is Carly at KHI. We have 5 recommendations highlighted in yellow. That is those related to quality assurance, which we've folded in a couple of things about the need to ensure and educate patients, ensure privacy and educate patients on privacy, as well as clearly established guidelines for quality to support quality assurance. A high priority recommendation flag related to reimbursement code, high priority recommendation flag related to both originating and distant sites, high priority recommendation about the need for telehealth around crisis services, and highlighting the importance of the ongoing conversation around state lines. That gets us to 5. I want to check in on those 5 and see if there is a strong case anyone on the phone would like to make that any of the other recommendations that are currently not in yellow rise above these, rise above the level of any of those. So anything not in yellow that is more important than the things we currently have highlighted. And I'll attempt to clean up the screen here so you can see things more easily.
All right, Carly, Representative Landwehr here, and you know, maybe we can put the state line issue. Maybe there's somewhere that we can combine it in our the top 5. But I think the issue of foster children and children in general within especially like within the K-12 mental health pilot program, et cetera, is that needs to be a focus that we take on, because I think you're going to see the Social Services Budget Committee, you're going to see the Health and Human Services Committee, and then the Seniors and Foster Care Committee make this a focus.
Mm-hmm.
And I think
okay, so looking for some guidance there, we'll need to do a 1 in, 1 out, or a combine one to get 1 out approach to add 1 in here. I think I'm hearing interest, Representative Landwehr, in the recommendation on row 107. So either from you, Representative, or from others on the phone, is there a place we can combine state lines in to another high priority recommendation? Or is there a proposal to remove that one from the highest priority list in favor of the recommendation in row 107?
This is Shauna Wright, and I wonder, can any of our recommendations get too big? Because listening to the representative and to Sunny, really the state line issue could fall under quality assurance, knowing where our providers are coming from and how they're licensed, that they understand what's expected in Kansas. And I agree with the representative about the foster care situation being a high priority. I know that quality assurance keeps growing, but I can see a strong argument for the state line issue falling there.
Well, and this is well, I mean, I completely get what Dr. Wright is saying is about making something too bloated, because when I look around as far as verbal consent and telephonic services, I see those getting wrapped up in, I mean, if we're going to establish guidelines and maintain quality, we're going to be talking about those things. So, but again, I don't want to overbloat one of our recommendations.
This is Gary from KDADS, and I agree with the representative. I did not see that, but I think that the foster care issue really needs to be one that's in our top recommendations. And I think you guys are all right in the sense that, you know, if we're looking at guidelines and things under quality assurance, many of the things that are listed below that have been mentioned would be included in that. But I do make them the foster care one a priority also.
And with
Lisa, did you have a comment there?
Well, yeah, just kind of. I feel like we're doing a lot to promote that foster care continuity of services with the revision in our CMHC contract. And I do know that some of these might be private providers. But I think we're going to see movement in that already. We're going to make that a priority.
This is Representative Landwehr. I can understand the agencies and some of our contractors making it a priority, but this is a living document for the legislature to follow, because what our experience has been, and I think that many of you have seen this since we've started this process, there's a lot of studies out there that are sitting in storage. And that's why it's so important for us to make this as clear and precise as we can, so that the 21 legislature, the 22, the 23, the 24 keep a focus on this issue, and it's part of us getting to our 10-year plan. I understand about bloating because we do have the first one on the quality assurance. I don't know, but what we couldn't put the state line underneath the originating and distant site, because the legislators that are on all of this, I think, would definitely take and understand what that means. But the foster care has got to be a priority. Just because that they got, the state got released underneath the Appleseed or whatever it was lawsuit, doesn't mean this issue is gone. And I can tell you from my experience, having been involved in the legislature since 1995 and heavily involved in the foster care area, nothing is different today than it was 20 years ago.
And Representative Ballard, let me comment on that as well. I was thinking we could combine with distant sites, but I would have to say that I was coming for foster care, because I believe that's the biggest issue we have in this state. If you ask anyone, everybody knows foster care has had a problem in this state. It is always there. And for us to have a recommendation where it is not specifically listed, it's like, how did we miss it when we know it's a big, big issue?
Yeah, then this is Lisa, what you said, I think it's not necessarily a bad thing that one of these recommendations may sync up with your mandate. I mean, that might actually be a good thing. That we have a little bit of a synergy with some of our mandates and our recommendations.
This is Shane Hudson. I do think that considering how state lines interact with originating and distant site would be maybe another line to add there that could tie in.
Great, thank you. This is Carly at KHI. I've made some of those notes there as far as, precisely where we want to drop that state line recommendation in. I will note that we've considered it combined above, and we'll get that clarified. There was, going back to an issue I heard a moment ago, I wanted to make sure I had notes correct as to all of the non-prioritized recommendations that I should be listing as kind of key issues under the quality assurance high priority recommendation. So I heard that we want to address provision of telephonic services there. Any other of these non-prioritized recommendations that I should be sure to include under that quality assurance issue?
Carly, this is Sandra with United. This doesn't go under quality assurance, but I think we could combine line 118. No, I lost it. Oh, 116. The parents connected to the welfare system up with the foster care recommendation.
Okay. Was someone else looking to make a comment there?
Yes, this is Representative Elizabeth Bishop. And I was wondering about 110 supervision hours and whether that would be consistent with quality assurance.
Discussion from the group there. Hearing a suggestion to make sure this is added as a note under the quality assurance recommendation as well.
I agree with that. This is Shauna.
This is Gary. I would agree with that.
Great. Okay.
This is Andrea Clark with KDADS, and I don't know that this specific point has been raised, and I think it fits under quality assurance. But support of electronic medical records is a really key piece to telehealth working. If a client or patient isn't an existing client, or the need to share records between providers becomes even more so of an important issue when you're not in person to be able to review a chart. So I know electronic medical records, there's definitely a varying degree of utilization and quality across all agencies. So
Representative Ballard, I agree.
Representative Landwehr, I agree as well.
This is Carly at KHI. I've made that note related to or next to the quality assurance recommendation as well. Okay, so what I'm going to ask the group to do now, I'm gonna consider this group here boxed in our high priority recommendations with a number of notes that need to be made about what all we are intending to say in that, recognizing that there's really a lot of work that needs to happen related to telehealth. So working group members, I'm going to depend on you to lead the way for this next recommendation or this next portion of our discussion, as we'll need to move pretty quickly. Similarly to other topics, what we are wanting to do now is label each of these recommendations as either ones for immediate action or recommendations of strategic importance. And so I have a little definition at the bottom of our screen here, but working group members, this is the definition you've heard before in our discussion on other topics. So recommendations for immediate actions are those that should be completed in the next 2 years. Alternatively, recommendations of strategic importance are those that we need to start now. We need to do this legwork, but it's going to be completed over a longer, maybe up to like a 10-year time period. So to the extent possible, if we can do this almost lightning round style, as we're getting close to the end of our time here, I'll first direct us to the recommendation on quality assurance, recognizing that we've combined a number of issues here, such as establishing guidelines, addressing the issue of state lines, addressing provision of telephonic services. Do we consider this recommendation of one for immediate action that we think can be completed in the next 2 years, or is it a recommendation of strategic importance?
Representative Ballard, I would say we could do that. I mean, that would be my high priority.
This is Gary from KDADS. I think it needs to be immediate action.
Okay.
Anyone
on the group disagree?
I would agree with that.
Okay. Colored that one yellow then to indicate we think this can be completed in the next 2 years. The next recommendation related to reimbursement codes. Is this a recommendation for immediate action? We think it can be completed in the next 2 years, or is it of strategic importance? We need to work on this over the next, up to 10-year period.
This is Sandra with United. I think it would be immediate action. We're getting hopefully to the end of the emergency situation, and these codes, some of them are going to revert back.
Representative Ballard, I agree.
Representative Landwehr, I agree.
Gary Hinault, I agree.
Okay. The next recommendation I see here is related to originating in distant sites. Is this a recommendation for immediate action, or is it of strategic importance?
Strategic importance, Gary from KDADS.
Representative Landwehr, I would agree with Gary.
Representative Ballard, I agree as well.
Very good. Moving us through then further, telehealth for crisis services. How would the group like to consider this one? Is this a recommendation for immediate action or of strategic importance?
Representative Landwehr here, I would say immediate action.
Representative Ballard, I agree.
Sandra Berg with United, I agree.
Gary from KDADS, I agree.
Okay. Then looking at our...
With this one too.
Sorry, Gary, go ahead there.
I'm in the same place for immediate action on the foster care.
Okay. Others on the group, and as a reminder to this recommendation, we did add in the recommendation about connecting parents of children in the child welfare system to services as well, or addressing those unique needs.
Representative Ballard, I agree.
This is Representative Landwehr, and I agree with what Gary says. I'm just thinking that the logistics of this and the details and some of the changes that would need to be made is this may be a 2 to 3 year process to get it to where we need. I'm not saying it's not an immediate need, because it is.
Yeah, this is Gary from KDADS. I agree with you. It's kind of falls in the middle.
Yeah.
That middle version. I mean, it's something we need to do now, but it's not something that will probably get completed in the next 2 years.
Right.
And,
I agree.
and this is Kyle Kessler, and I would say that is the difference between what can we do and what should we do, because this is a challenge, and this will take integration and integrated efforts between 3 state agencies to work with stakeholders in all 3 of those areas. And we don't have a great track record with this population. I mean, and it's tragic is the reality that we don't. So
I think the important thing is we've made it a priority.
I guess I'm done.
Yes.
Well,
Sorry,
and
sorry, Kyle.
No, Representative Landwehr here. I think that, definitely this priority has started with the work in the K-12 mental health program, because its #1 focus has been the foster kid. Those were considered the alpha kids in our group. And it's really expanded beyond what we originally thought, which is a good thing. It's sad that we have to, but it's a good thing. And I think that we're going to be a long ways down the path on being able to help address this. I think it's going to be important as we have these discussions that we're not talking to just the agency or the contractors, that we are talking to the foster parents, so that we get a better understanding and a handle on what their needs are, because that's where our problem's at. The problem is not the agency in Topeka. And for me, it never has been. I can sit down and have these discussions all day long with the secretaries. But we've got to get down into the people that are actually providing the services and doing the work. So the 2 groups is then the regional offices have to be doing their job, providing the tools for the parents. And that's a gap that's been there as long as I've worked on this issue. Yes, I'm passionate. Can you tell?
No. No, I'm sorry. You guys should understand, Representative Landwehr, and I do this. I do just have one question. I know we prioritize and everything else, but does that mean that jail reimbursement or just jails are out?
Representative Ballard, this is Carly Houchin at KHI. So what we'll do is all of the recommendations will be preserved in appendix, so that whenever there's the space or the opportunity for additional conversation, all of the work and language, negotiations there is preserved, so it can be taken up at a later date. But I don't believe I have a note that it's been combined in any way to be included in the highest priority recommendations.
Representative Landwehr here. I think Representative Ballard, how I see this kind of going forward is if the 3 major committees, then along with the PROPs, work together on this, these other items that are not in the top 5, we may bump up against them and say, yep, we've got to pull that up into that. So it's not a dead issue. It's just not sitting in the top 5, but it does not mean.
And I agree with that. But thank you. I just didn't want it to get totally lost. Thank you very much, Representative.
I agree.
Okay, so this is Carly at KHI. We have our highest priorities, and we kind of have them sorted into those 2 categories there. So that will leave, I believe, the following recommendations in our appendix, and just going to run through them to make sure I'm not missing a note that we've added them, that we should have added that language or added that as rationale to some of the higher priority ones. So the issue of verbal consent will be something that's captured in the appendix. The issue related to telehealth care coordination will be addressed in the appendix. The issue of broadband will be addressed as an appendix recommendation, as well as jail telehealth services. Anyone have a note or remembering discussion where we put any of those somewhere in the high priority recommendations that I've missed in my kind of rough note taking here? Okay, seeing shaking head. So I think we're okay. And I think that means we have achieved our primary goal of our meeting today, which was getting, it's hard fought, but we've gotten to top 5 priorities related to this that we will put forward in the product for the special committee to consider. Just to fill the group in on kind of next steps here, this is the last subgroup meeting related to this topic. As working group members are aware, The meetings of the working groups are continuing as we're finalizing priorities on other topics, and then have meetings scheduled for the first week of December, where you will get the chance to review your work in the product form that it will go to the special committee. So how we'll plan to handle this issue is that I'll try and flag this telehealth section for the working group members who are on this call. I'll have those sections flagged for you whenever you're reviewing the full report, so that if there are any corrections or places where we've misrepresented the conversation, you can offer those corrections to us at that time. But from my perspective, that kind of wraps up what we were hoping to accomplish today. We have 5 high priority recommendations. I want to thank working group members, of course, for getting on these additional calls to address this issue of telehealth. I know it felt lightning fast, but I think there was some really productive conversation had. So thank you for that. Also want to be sure to thank the supplemental experts who I think of those still on. We have Shauna and Shane and David Jordan and Dr. Nelson. Thank you to all 4 of you for giving us a few hours of your time this week. Your input was invaluable in clearing up some of the key issues around this. But want to pause there to see if there's any questions on logistics or process before we wrap up our call for the day. Okay, seeing shaking heads. So thank you again so much, everyone, for your work. And with that, I will consider us adjourned.